Time. I know that we've got a brief meeting today. Just to let everyone know that we will be recording today's session. There were some folks that were not able to make it. So we will have the slides and the recording made available to all of the advisory committee members. Again, thank you all so much for joining us today. My name is Lisa Inohasa. I'm the Senior Program Coordinator for NPRQI, and we're going to go ahead and get started. So, just a few brief introductions. We have added quite a few staff since the last time that we've met. Most of them are on the bottom row of the slide. Just a quick introduction. We have Andrew Payne. He's a data analyst for the Department of Pediatrics at Dell Medical School. We have Ying Chao Yuan, senior biostatistician with the Department of Peds at Dell Medical School. We have Choi, who is the I cannot talk today, data visualizationist with the Department of Peds at Dell Medical School. We also have Beverly Swanson, who is the administrative assistant for NPRQI. We also have Amy Ryland, our communications strategist, as well as Casey Patika, who is the Senior Administrative Program Coordinator. So just a brief acknowledgments that NPRQI is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services, as well as the Toyota Way Forward Fund. The contents of today's presentation do not necessarily represent, nor are they the official views or an endorsement by HRSA, HHS, or the U.S. government. And just a reminder that the University of Texas, Austin IRB has reviewed this initiative in full and has determined that the project is exempt from human subject research. So some of you all that are on the call today have been with us for the entire ride of NPRQI. Others are fairly new to the program. Just to acknowledge that we have some SMEs that have really helped to provide direction on clinical areas of focus. We also have QI AAB members that really help to develop the Delphi process to create the NPRQI measures, and stakeholders who have been our amazing ambassadors. We just wanted to share with you that we're really going to do kind of a reflection of NPRQI and really kind of do a look ahead in terms of sharing the impact that we've made, the ways that we've grown over the last 5 years. And just know that while this may seem like a formal kind of conversation, that it's the NPRQI team. And if you have questions, we really invite you to speak up as we go along. You can unmute yourself, you can put questions in the chat, and we'll be happy to address any questions or engage in meaningful dialogue with you all. So we know it's been a while since we last met. We're excited to share a brief overview of where NPRQI is now, 5 years in. As of March 25th, as of March 2025, we have 153 participating EDs that have executed POAs. As you recall, NPRQI was really designed with low resourced and low pediatric volume sites in mind. We have been very intentional about who we engage with this specific demographic. And we're excited to share that we've got 91 of the participating sites in NPRQI report that they see fewer than 5,000 pediatric patients per year. 105 sites report that they have designations of being a trauma center, a stroke center, STEMI ACS designations, which really kind of tells us that these sites already have a lens for quality improvement, and that NPRQI is really helping to bring a pediatric perspective to that QI lens. We also have 62 sites that have a rural or remote designation, which really kind of represents a little over 40% of all participating sites. We have, as of March 2025, we had over 20,000 ED visits entered into the data platform. So this slide really highlights NPRQI's national reach and strength. As of March 2025, we have 32 participating states and territories, totaling 153 sites with an executed POA. The map that you see on the left really illustrates the number of active or participating states and territories, specifically those in the dark green states. And while we are excited that we've made great strides with engaging sites, you can see that there is some untapped potential in those lighter green states. So if any of you all have ideas or connections specifically in those light green states, we would love to connect with you. The second half of the screen really illustrates the power of NPRQI based on the number of participating hospitals and their pediatric patient volume. We estimate that NPRQI has the potential to impact up to 1.1 million pediatric patient lives. Now I'm going to hand things over to Crystal Bartley, who's going to provide a deeper dive into our engagement activities.
So good morning, folks. So at the onset of NPRQI, we always ask ourselves, how do we get this platform into the hands or at the sites that could benefit most from having a QI platform that was free, that was easy to use to engage in quality improvement efforts, and that would help them really drive their outcomes related to pediatric patients. And so our team identified 4 sources for recruitment. We focused on emergency departments. We did our recruitment efforts, or what we are calling levers of engagement, with healthcare networks. We have some efforts related to regional service areas. And then lastly, we have our state and national efforts. And so the next series of slides, what we'll do is sort of walk you through each of these engagement strategies or levers for recruitment and talk about some of the challenges as well as some major crossroads that we've made with each of those groups. So when you look at the emergency departments, we have about 228 that are formally registered in our system. And then we have 153 of those that have fully executed their participant organization agreement. And of those 153, 121 of those are EDs that are actively entering data into our platform. And we think that this is our greatest strength, is that we have it in the hands of our core users. This also means that we have some delays that are occurring. And we see our biggest bottleneck that's happening is with the submission of the POAs. There's usually a time lapse, or there are some sites that just have not been able to establish those submissions. And then we see some delays in data entry. And our team has made some crossroads in the last, I would say, year to help sites enter their data. And it could be that we're hosting office hours where they have one-on-one time with our team to address any technical issues that they may have. It could be that it's a new nurse that's just learning how to do quality improvement. And so we're showing them the impact of their data, how to search for opportunities for improvement. We have developed communication to share with their care teams as well as their hospital leadership. And we're still providing some other sort of alternatives to keep those sites engaged in the work. And so some of you on today's call, we know, have actively helped us with site recruitment. Do you want to give some insights on what the experience has been, either as part of a collaborative and your hospitals participating, or if you've had one-on-one conversations with any of your stakeholders. Okay, we got a quiet bunch this morning. Well, we'll walk you through the next set of recruitment strategies. So then the one that's next up are our health networks. And so we realize that this is definitely one that's an unmet potential that we want to capitalize on. While we are engaging with networks, we do still want to balance that autonomy of the individual sites. And so that's one of the greatest challenges. We have 13 networks that are currently registered. Of those 13, 3 of them have actually executed a POA, but none of those sites currently have access to the dashboard. And I would say that we have a strategy in place to ensure that we keep those sites confidential, and that threshold is that it should be a minimum of 5 participating sites within a network that give permission for the networks to see their data, and we just haven't quite reached that threshold yet. So if you're a part of a healthcare network, or if your site is working within a network and they haven't sort of let us know that they're interested in doing network level evaluation, please let our team know. Some of the things that we're doing right now is meeting one-on-one with these health networks to understand their concerns, and we're sharing one-pagers that they can use with their ED leadership and C-suite team to increase engagement. So Lisa, let's go to the next slide, which is our regional service areas. And so this one's definitely a different approach than we had initially brought to you all in the past, but we wanted to definitely share this information with you. The regional service areas are unique in that each state has their own particular infrastructure, but it's typically on a state level, and the organizations or the structure of it is based on regulatory framework or regionalized care systems. That oversight or governance will typically have a set of policies, expectations, and performance outcomes associated with it. Each state has their own design. So for the state of Texas, we call them regional service areas or trauma service areas. And our hope is that we are able to align with each state's sort of infrastructure that they're using to guide this work. And so we'll see on the next slide that we'll give you a sort of a focused approach of what we're doing for the state of Texas. So in 2024, there was the strategic plan that was released that really highlights some of the efforts that are happening statewide to drive the healthcare system. We, within the state of Texas, have 22 of what's called a regional advisory council, or 22 RACs. They are geographic specific to our trauma service areas. And so one of the pillars in the strategic plan is about performance improvement and patient safety. And it highlights the need for including pediatrics in those sort of systems, and also having a strategy that can be used to share evidence-based practice. Texas has also released new trauma rules. And so with that new trauma rule, we've been able to align ourselves specifically within these trauma service areas to provide the NPRQI tool. We are currently working with CATRAC, and you'll see them listed here. So their coverage area is for Central Texas. It covers about 3 million people with 29 counties. And you'll see the other stats that are listed here. And Kate, do you want to provide any other sort of information about Texas' impact with the trauma rules?
No, I think you've covered it mostly. I mean, I'll just add that because of the Texas trauma rules and the requirements bound pediatric readiness, there has been a lot of effort to figure out how to support level 3 and 4 trauma centers across the state. Texas has over 300 trauma centers in this state alone, and over 200 of those are level 3s or 4s. And so there has been concern voiced from the trauma centers. How do we meet these requirements? How do we achieve the standards that are expected. And a lot of that is being pushed down through the ranks. So within the state governor's EMS and Trauma Advisory Council, where most of the stakeholders are gathering together, we have gotten support for a statewide pediatric readiness improvement project that includes 4 specific arms that have been endorsed by GTAC, and NPRQI is one of those, recognizing that quality improvement is a mechanism to ensure our trauma centers are doing the best they can for children. Thanks.
And so the next slide, Lisa, we're going to spotlight one of our successes within NPRQI, and that's Schleicher County Medical Center. They're a rural critical access hospital that's typically has low pediatric volume. And they, after nearly 5 months of entering data into NPRQI, they reached a standstill because they had limited staffing. And so some of the sort of initial barriers was that the CNO was balancing multiple roles. She had no time for data entry. They were unfamiliar with the data system and doing quality improvement. And as Kate mentioned, there's that new need for meeting these new Texas pediatric trauma rules. So she actually came up with a creative solution. They identified a night nurse that currently enters data into the trauma registry and decided to double dip. And so that individual is now entering data for their trauma registry and NPRQI during their night shift. And so we were able to give the proper sort of access to that individual with the training that they needed to be able to enter data. And so this is like a real life example of you have new trauma rules or new sort of mandates that are coming down. Sites are overworked and they don't have the bandwidth. How do you actually get them to adopt this tool and use it in practice? And so we're pretty happy about the results that we're seeing. One of the efforts that we're still maintaining are those office hours that are provided twice a month to sites. And we have that resource that's going to be available in a different sort of forum coming soon with more details and more targeted support, especially as we expand to other regions within Texas. And so, Lisa, can you go to the next slide for me? And so when you take a look on the right-hand side, it's not just Texas. So you'll see that these sort of formalized groups or health systems are also exist within Illinois, California, and Pennsylvania. The names are different and how they their catchment areas have different designs. So it's not just the trauma regions, but we have had contact with the groups that are listed here. And so if you currently are interested in getting a particular region working with NPRQI, please reach out to Lisa. We are definitely recruiting them, and you'll see on the next slide that the opportunity, or we are, how would you say this? There's room for growth. It's fertile ground. You'll see on the left-hand side the number of states that have POAs executed. And then you'll see on the right-hand side those active state dashboards that are available. So even our EMSC managers are able to see what the performance looks like on their state level. And so do you all have any questions about these sort of efforts so far before we drill down into some of those state or national initiatives?
Crystal, it's Marianne. By the way, this is phenomenal. It's so hard to get these things stood up. I'm on the CARES advisory, and they're still struggling even with ongoing funding to get all the states to participate. So it's the POAs. Are those the biggest barriers, you think? I'm just trying to see if there's ways that maybe this group could help out by reaching out to a number of states and working with them for agreements. And it sounds like getting someone to enter data is a barrier, but I think that POAs also are a barrier. So
I think you guys have the greatest amount of influence in the recruitment and getting those POAs established and helping sites understand that we sort of have established security elements to ensure that their data is confidential, even by being a patient safety organization. But Kate, what are your thoughts?
Yeah, I mean, thanks for that, Marianne, and I appreciate the comments. And yes, it is challenging. Yeah, I think the biggest challenge that I believe leads to the delays in the POA is not understanding the risk, which is that a lot of people
Yeah.
think that we're asking for, patient names and dates of birth and all this PHI data, and we're not. We're we're only asking for date and time of arrival. But so many of these networks have established these very robust security assessment processes, and they ask for very specific questions, and they have to go through, all of the layers of that in order to get approval. And one of our challenges has been that, as I think you all know, we've been reliant on a vendor for the platform and are under a non-disclosure agreement. So we can share so much, but we can't share everything. And while the risk is really low, I just don't think it's quite appreciated, and it's hard to get that message across.
I'm a little worried about the time. The date may be one thing, when you look at what is a limited data set and what potentially could identify a patient. My
Yeah,
concern is that the time will be able to identify the patient.
right.
And I think that's probably where people are really pushing back.
Yeah, and that's a challenge for time-based measures, right? Like you can't tell people the time to an intervention if you don't have a time of arrival. We are looking at potentially doing some like live restructuring so that it goes to a time zero and they don't actually, record or maintain the time. But again, these are entered into a system where it's, a hospital identifier and, the amount of work that would take to go in and try to find I mean, we don't even present outcomes on one patient. So it would be extremely difficult to identify. Um, but
Can you
even,
do the time to intervention without meaning the delta time without putting the time of arrival? I'm just trying to problem solve here because I feel that the time of arrival is going to be able to identify a patient,
yeah,
and that's a big pushback. I've had that with our argument with our IRB, and
yeah.
uh, you know, uh,
Yeah, it's a good question too, Amber. Is time decoupled with the date? It's not currently because, if a patient comes in after midnight or before midnight and then is still being cared for after midnight, the date changes. And so, in order to get a delta, you have to have the date and the time linked together. I think it would be increased cognitive load on the users to ask them to create the delta. Um, do you all?
yeah, yeah.
But we could do that. I mean, if this group feels like that's the best approach.
Yeah, I don't know. I wonder if you could do like a mini test, take a couple of sites and have them do the delta times and see how burdensome it is for them to do that. Anyway, I
Yeah,
just hard.
it is hard. Yeah. I mean, the fact that we have 150 sites, that have their POAs signed and are, good to go is reassuring. And certainly the smaller sites, they're not, going through all the layers of bureaucracy to get their POA signed. And on average, it takes about 30 days, which is phenomenal. But it's many of these other sites that we just can't get past those barriers. So I appreciate these ideas, though. This is helpful as we kind of think through how to approach it. And good luck on your grand rounds, Marianne. Thanks for joining.
Thanks.
Casey, I think you are up.
Oh, so as Crystal was sharing, we've seen success in engaging key players at the state level, as displayed by the number of POAs executed in each state. We attribute this success to our collaboration with one of our key players, the EMSC State Partnership Program Managers. As states engage more EDs, the program managers gain access to their state's performance dashboard, where they are able to view their state performance and then compare this to the national performance. Currently, 7 states have engaged the required 5 sites to view their dashboard. These states with access are California, Texas, Colorado, Nebraska, Missouri, Kentucky, and Illinois. Kentucky, Illinois, and Colorado are actively utilizing their platforms to identify areas of focus for statewide improvement efforts, as well as a tool to support EDs in completing quality improvement requirements for pediatric readiness recognition programs. Then looking at a broader engagement approach, we've seen the power of quality improvement collaboratives and engaging participating EDs at the national level. In 2023, we partnered with the National Pediatric Readiness Quality Improvement Collaborative, which engaged 92 emergency departments that registered for NPRQI and began utilizing the platform to support their quality improvement efforts. Over an 18-month period, this partnership proved to be successful for recruitment, as participants were engaging with the platform and received support from the collaborative facilitators and other participants, which helped them implement quality improvement efforts. 74% of the participating EDs identified a SMART aim related to either weighing and recording pediatric weights in kilograms only, pain assessment, abnormal vital sign reassessment, or suicide assessment. While 66 EDs share that they implemented change strategies, including staff education, equipment updates, EHR modifications, and policy and procedure enhancements. Ultimately, 45 sites reported improvements, including enhanced pediatric readiness, improved patient care, and increased satisfaction among patients, families, and staff. NPRQI provided these sites with meaningful pediatric quality metrics and a data platform to guide improvement in the delivery of pediatric emergency care. With 13,424 patient records entered by 80 of the PRQC sites, these sites have been able to track their quality metrics, performance, and support their local quality improvement efforts. And many of these sites have reported improvement in their individual quality metrics. So I will hand things over to Dr. Desai, who will help us take a closer look at the data.
Okay. I'm going to chat a little bit about patient-level data and aggregate findings on our dashboard. Most of these reflect findings from the year 2024. So this includes about 15,000 patients that were entered with ED visit dates between January 1st and December 31st of 2024. We just wanted to characterize our patient population a little bit and offer some opportunities for reflection from the group. As you can see, we have a pretty diverse distribution of ages, roughly about 25% under 2 years old, and then in the other age categories as well. We have a relatively even split between genders, and about 60% of our patients are publicly insured or uninsured. When we look at patient dispositions, we have captured about 76% of patients that are discharged home, about 8% that were admitted, and nearly 13% transferred to another facility. We also looked at the ESI triage levels for our patient population, and most commonly we have patients of ESIs 3 and 4, there were a subset of sites that had not adopted ESI as they began working with our platform. And then finally, we looked at a breakdown of chief complaint categories, with about 70% of patients having a medical chief complaint and about 25 having an injury, with about 5% behavioral health. Next slide. As you remember, NPRQI presents data or collects and presents data in 7 bundles that include the most common clinical conditions that are seen in emergency departments. All patients are entered into the assessment bundle, as well as those that are transferred into the interfacility transfer bundle. And then based on the chief complaint, as well as the ICD discharge codes, patients are pulled into one of 5 other groups. That includes blunt head trauma, seizures, respiratory complaints, vomiting, and suicidality. So preliminarily, here are some of our national aggregates for some of our measures that have the most data in them. So this is from the assessment bundle. And just a reminder, our national performance currently is calculated as the average of site performances. And so for patients with weight documented in kilos only, we have a national performance of 61%. Patients with pain assessed, we're at 81%. And for high acuity patients, that is ESI 1, 2, and 3, with a vital sign reassessment, that's an 83.6%. In our suicidality bundle, one of the measures that a lot of sites are working on is a portion of adolescent patients, so ages 12 and older, who received a structured suicide screen, and our national performance is 97.6%. And then in the head trauma bundle, we have a few measures that we're tracking. So percentage of pediatric patients with a full set of vital signs obtained is at 62.6%. Percentage of pediatric patients that had a Glasgow-Coma scale or GCS reassessment is at 31.2%. And then we have the proportion of pediatric patients who received a head CT that also met at least one PCARN criteria for head CT is at about 76%. I think I'm going to stop here and just leave some room for questions about our preliminary data, what else you'd like us to be tracking, what else you'd like to see from us. We'd love to discuss our preliminary findings with you all.
So
I just wanted to know, oh, go ahead, Kate, sorry.
Oh, sorry, I was just responding to Erin's question. The head CT metric is odd. They're kids that meet criteria not getting scanned. So these are of kids who who had a head CT performed. What percent of those met PCARN criteria for obtaining that scan? So there are kids that don't meet criteria that are getting scanned, and that's what's essentially being represented there. That 25% or so of children who got head CTs did not meet PCARN criteria.
Yeah, I'm seeing Teresa's comment. I am very interested in transfers as an area of work, and you're right, that 12% number is much higher. I think there's a couple of things in play. I think overall, sites are losing pediatric capabilities and kids are getting transferred more for, simpler conditions that they would provide definitive care for. And then I also agree that since we have 62 rural sites and many that see very few pediatric patients, we may be capturing a subset of hospitals compared to the national average that has fewer pediatric capabilities, and so a higher transfer rate. The other question that comes up with the transfer is also how are people sampling patients? And as far as we know, most folks are doing a systematic sampling. So they will enter every 10th chart, every 20th chart. And so I'm not really concerned that, individual sites are entering only their transferred patients, for example. Are there any other metrics that the group would like us to present, or anything else you're curious about in future iterations of this?
Just as an example, we don't have probably enough numbers to start looking at, differences across states. We did not present today user engagement numbers or what that looks like. We have other kind of metrics that we could be looking at. We could look at ranges. There, those are just some possibilities of things, as we think about future data to share.
So if there's no other questions or discussions about the data, we're going to move into communications. I'm going to hand it over to Amy Ryland, our communication strategist.
Hello. So over the last 7 months, we have developed a new suite of communication and marketing materials designed to support NPRQI in the participation as well as the recruitment efforts. And these were created out of the feedback this group has received from all of you in ways to advocate for NPRQI. So these resources include a customizable promotional package that various site users could use to help talk to their C-suite as well as their leadership, or for individuals who think that a site should have it and have a connection there. We have completely overhauled the NPRQI website to really make it a stronger user experience for those going to the site to learn not only about NPRQI, but for the existing participants as a login and a resource center. And then we've also created some additional resources in terms of a quick start guide, infographics on the impact of NPRQI, as well as I know Crystal mentioned earlier that we've aligned ourselves with the Texas trauma rules. And so what we did was try to pull together a tracker for sites to ensure that they're meeting those trauma rules through the lens of NPRQI for various elements of that set of rules. And then we just encourage you all to explore these. They're all hyperlinked on the presentation that will be shared out. And let us know if there's anything else that's maybe missing that you would find to be helpful in advocating for NPRQI. And I'll turn it over to Kate.
Great. So just next things on the horizon, funding and sustainability is always on our mind, as many of you know. There's a lot of questions regarding EMSC, and we hope that similar to prior years when EMSC has been under threat, that the funding is able to continue. But we are grateful that we've been able to obtain some funding through Toyota Way Forward, and are continuing to strive to identify other potential resources, funding streams, charitable organizations, and the like. The other piece that we're working on is some system upgrades just to make this a little bit more user-friendly. The current system really functions as almost three different parts: registration, data entry, and then dashboards. And so we're really trying to integrate those under one umbrella that allows it to be much more seamless. And we're really excited about that. We hope to be able to roll that out towards the end of this year. From both Lisa and Crystal a little bit about how we're doing with that. Certainly, Texas was an important starting point just because of the new Texas trauma rules, and also related to the specific funding that we received through Toyota. But we know there are many other states, either through public health authorities or trauma service regions or EMSC regions and the like. And so we are working to support the particular healthcare landscape. We are also beginning to explore electronic data entry, and with that, some of the things that you all have talked about. Do we need an embedded calculator so that we can get rid of the time entry that would lessen the potential risk or perceived risk by sites that are participating, but also to be able to offload the work on individuals in terms of manual data entry. So we're in the process of exploring this. We're hoping to undertake a pilot effort in that regard over the next 6 months or so, and then we'll have more to come after that. We also have recently started thinking about other low volume populations that are at high risk and may not have widespread resources available. And that particularly relates to the obstetrical population. And going with the kind of adage that maternal health is child health is maternal health, might we be able to explore opportunities in that regard? So we've recently partnered with some Texas-based stakeholder groups in the perinatal and obstetrical space about creating some process measures that would allow us to, in the next few years, potentially expand to include obstetrical measures. So how to, acutely manage things like eclampsia, preeclampsia, hemorrhage, and the like. We continue to work on growing our data registry. We've been doing a tremendous amount of work of just kind of cleaning the data, making sure that everything is as it should be in terms of, logic and that there aren't any misses in terms of, calculations or if there are certain measures that are really difficult for people to enter. So really just doing some deep dives into the data registry to try to make that as robust as possible. What we have decided to do, and I think we've shared in the past, is that we will be creating annual registries for the data. So we'll have a 2024 registry, which will run through the calendar year, and then a 2025, 2026, and so on and so forth. And that we hope will allow the opportunity for individuals to engage in this registry for research queries or deeper dives into some of the data that's within here. And then lastly, we have partnered with the EMSC Innovation and Improvement Center with collaboratives and now are formally embedded with the EMSC Innovation and Improvement Center, wearing both of those hats currently. But what we have done is made sure that the Peds Readiness Quality Collaborative can utilize the NPRQI platform in order to drive those improvement efforts. So we just finished up one Pediatric Readiness Quality Collaborative just this past year. And we'll be looking to an upcoming repeat of the Pediatric Readiness Quality Collaborative beginning in January of 2026. At this juncture, we're not entirely certain what the clinical areas of focus will be, if they'll be the ones that were used previously, which was assessment, pain, vital signs, and suicidality, or if we'll be expanding to encompass some other areas. But we're excited about those. We know that they're really a critical piece of helping folks to engage and understand what it means to engage in continuous clinical quality improvement, really looking at patients, looking at data, and driving their own improvements locally. And I think it really does empower pediatric emergency care coordinators and those teams to be able to demonstrate back to leadership how important this work is. So looking forward to that and excited about that on the horizon. And I think with that, we are pretty much done with everything that we wanted to share, but we'd really love to just open it up for questions and comments, and appreciate you all being on this journey with us over the last, 6 years now. It's taken us a long time to get here. We're pretty excited about where we are, but we know we have a lot more work to do. And really, we just want to make this as easy as possible for folks to use. And the hopes that we can, not, I think Diana's on the call and she heard me say this yesterday during a state meeting, but I don't think that access to high quality care should be what differentiates one hospital from another. And our goal is to make sure that every hospital has the ability to ensure high quality care for children based on their local resources. Resources might be a differentiator, but high quality care shouldn't be. And that's what we're trying to really change here. So happy to take any questions, comments, would love your thoughts. How can we do better? What's concerning to you? What do you like? Suggestions? We'd love to hear.
There is a question from Mike in the chat about suicide screening. Questions about how to capture the last 2 to 3%. I was just going to reflect on that as we engage with hospitals. And as they, one of the things they usually do is they'll enter baseline data for 2 or 3 months, and then they'll come back with us and reflect on their dashboard. And so the hospitals that typically decide to focus on suicidality are often those that are way below the national average. So if they're performing at 60 to 70%, and they see the national average is so high, those are the ones that are really targeting improvement in that realm, because it feels like where they could get an important area where they could get the most gains. So I would say our approach hasn't necessarily been focused on getting the top performer, the average or above average folks to hit 100%, rather than bringing those who are below average up. But Kate, I don't know if you have other reflections on that as well.
Yeah, I think there are pockets where we see some significant differences. I think the act of universal screening is really critical to emphasize. And I don't know if Patsy is on or not from the Joint Commission, but universal screening is certainly something that the Joint Commission has tried to emphasize. And Jem, maybe you want to speak to this too from the standpoint of ACS and trauma, but one of the items in the Texas trauma rules also is that any patient over the age of 12 that's admitted should have suicide screening. So really trying to leverage some of these other stakeholder groups and entities and understanding that and making them feel a little more comfortable around the screening pieces too. So. And then Evelyn, thanks for your comment. The exploring maternal child health measures would be beneficial and would assist state EMSC programs in being able to better link or leverage with their state Title V programs. And yeah, we very much agree. And there's been really a tremendous amount of work in terms of maternal and obstetrical health and measures. And there's been a great job identifying outcome measures that have been put forth by ACOG, the American College of Obstetrics and Gynecology, but there hasn't been a lot of work in the area of developing process measures. And so we feel like this platform provides an opportunity to at least start driving improvements of, if we see hypertension in a pregnant woman, how do we, treat that immediately and aggressively, and, these sorts of things to really impact outcomes. So most states are tracking the outcomes, but most EDs aren't tracking the process measures. So thanks for that.
Any other last thoughts or reflections on the information shared today?
Just a quick comment to Mike. So Mike, we were able to receive additional funding through Toyota that'll keep us alive and going for at least another 2 years. We would like for that to be in partnership with EMSC, as it has been since its inception in 2019. But we will also continue to look for other sources of funding. So we're at least good for another couple of years, but we really want to make sure that we're able to keep the funding going beyond 2027 and hopefully beyond 2030. And we'd love for this to be universally available. So hopefully that answers your question. Yeah. And thanks, Teresa. We really couldn't do this work without you all. I mean, we really appreciate your thoughts, your ideas, your suggestions. We'll look into some of these items that you all suggested related to time and radiation dosing, and certainly integration of OB and maternal measures and calculators and things like that. And we will keep you guys posted. We really can't wait to show you what this is going to look like with the system upgrades, and hopefully we can share that with you next time, and maybe we can share a little more on user engagement metrics, and also what we've tried to do to overcome some of the barriers around POAs and data entry. And I'm hopeful that we'll have some exciting news to share on both of those fronts. I think just in terms of, being respectful of everyone's time. We hope that the Q6 month meeting pace is good and enough to keep you guys abreast of what we're doing. We worry that maybe quarterly we won't have quite enough to share. But for those of you who have been SMEs, we may be reaching out to you separately because we would like to do some little more deep dive into some of the data elements. So just FYI, I think that's, Erin, Libby, a few of you that we've worked with in terms of really designing this from the get-go, but really grateful to all of you. Again, we couldn't do this without you. So thank you.
Okay, so to close things out, we do have a brief video that we wanted to share. This also came about as a suggestion from this group as well, along with several of our other communication and marketing products. This video can also be found on our website, and we'll put the link to the website in the chat as well. And just apologies if there's any technological glitches with this, but we're excited to share this with you. My name is Lisa Inohasa, and I'm the mother of 2 teenagers. I would do anything to make sure that they get the best care in an emergency. Emergency department teams share the same goal: to be prepared for children's unique health needs, otherwise known as pediatric ready. Being pediatric ready requires a specific, systematic approach that supports clinicians to deliver the best pediatric care possible. This saves lives. In fact, research shows pediatric readiness can reduce mortality risk in children up to 76%. Even though the benefit is clear, most emergency departments only see a few pediatric patients a day. This can make it challenging to ensure systems are optimized for children. The National Pediatric Readiness Quality Initiative, or NPRQI, was created to bridge this gap. NPRQI is the first of its kind data visualization tool that makes it easy for emergency department teams to measure, reflect, and improve pediatric care. NPRQI's free data dashboard empowers teams to look at the patient experience holistically, to examine the system of care as it currently exists. When variation or gaps in care are seen, clinicians can take steps to improve. NPRQI was created for all emergency departments, regardless of size, specialty, or pediatric volume. Over 100 hospitals across the nation are already using NPRQI and making a big difference in the care they provide for children in their communities. It's fast, secure, free, and easy to use. No special experience is required.
NPRQI is free, easy, and self-paced. It's definitely been a game changer for the care that's provided within our rural emergency room.
Join the national movement to become pediatric ready. For more information, go to our website, www.nprqi.org, or scan the QR code and let us know that you're Sorry, I cut that off a little bit too short, but it's also on our website as well, so you can view that there. Thank you all so much for joining us. We really appreciate you taking time out of your schedules to engage with us and continue on this important journey that we have. So we will be sending out the slide deck along with the recording. So folks that weren't able to attend will be able to listen to the information as well.